Today I'm going to talk with you about acute pain management in individuals with opioid use disorder. This was first presented for the Providers for Clinical Support System in conjunction for the American Society for Pain Management Nursing, and now I'm recording it for your use and information. I hope that by the conclusion of this talk, you'll be able to better discuss acute management strategies for those with pain and active substance use. Talk more about medications for opioid use disorder, which has previously been labeled as medication-assisted treatment. Develop treatment strategies to treat acute pain for individuals with substance and opioid use disorder. And finally, describe safe discharge strategies for the patient with acute pain and substance use disorder. It's a balancing act. We have clinicians' fears. We may be not confident in our ability to even assess substance use or treat substance use disorder. We may worry about the mental health issues and perhaps complex psychosocial situations with people with substance use disorder. And we tend to want to avoid caring for these people. And then there's the individual fears. Someone having had substance use or opioid use disorder may fear that they won't receive the pain management that they need because of the stigma surrounding their substance use. And many times it's happened, so it's a realistic fear. So how do we balance both of those? And so the general considerations is that we need, as clinicians, to advocate for safe, appropriate pain management in individuals that are using substances. I mean, this is a chronic, recurring disease, just like diabetes, just like heart failure, and it's not a moral failing, and we need to be able to advocate that people get and receive the pain management they need in the acute care setting. We want to utilize a harm reduction approach. I personally am still trying to get my arms around this one and am I really doing harm reduction, and really learning more about that. We want to maximize the use of multimodal analgesia in the acute care setting. And this is using agents from different classes of medications to have a synergistic approach to managing pain. We want to consider treatment for mental health issues, which is very difficult to do in the acute care setting, but is it potentially the opportunity to help link people with treatment? And then obviously collaborate with the prescriber if the person is receiving medications for opioid use disorder and comes into the hospital or acute care setting, or if you're going to start someone on medications for opioid use disorder in the acute care setting, you must make sure that there's someone to carry on with the prescribing after discharge. I think we all know that language matters. We see this in so many different realms, the need to appropriately use language. And language matters in this population and can be a source of stigma. When we say the word addict, junkie, user versus person with substance use disorder. So the preferred language is to name the person. It's just like not saying that liver patient in 332 or that heart patient, person with liver disease, person with heart disease. The same respect we should give to people who use drugs. It's a person who uses drugs. It's a person with alcohol use. It's not an IV drug abuser. It's a person who injects drugs. Medication-assisted treatment moved over to medications for opioid use disorder because it is a mainstay of treatment. It's not an assist. It's almost like saying an insulin diabetic, insulin-dependent person with diabetes. We're saying that insulin is a medication for assistance. No, it's needed. Versus medications for opioid use disorder that we know work and save lives. Instead of using the word relapse, return to use used. Recovering addict, a person in long-term recovery, remission. Instead of failing drug test, dirty urine, testing positive on a drug screen. I adapted this slide from my colleagues Katrina Nichols, Monica Holben, and Janet Ho. We presented together at the American Academy of Hospice Palliative Medicine. And the source of these really comes from the National Harm Reduction Coalition. So it's really accepting, for better and worse, that, drug use is a part of our world, and people that use drugs may have recurrence of use, and no one grows up thinking, gosh, I want to grow up and become a drug addict. This is what I really want to do. But we have to remember that once someone is in that cycle with an opioid use or substance use disorder, where they're in that binge intoxication, where initially that produced a memorable or pleasant. Now it's the binge intoxication, and the seeking of the use of drugs is really to avoid the actual withdrawal. And we don't want to minimize the reality of harm. I mean, we want to be honest with people that, their injection drug use, especially in this day and age with illicit fentanyl, could lead to their death. But that we understand the continuum that, from casual use to risky use, all the way through to the continuum where you have someone with a significant substance use disorder who is using drugs every day, who might have had, many instances of ending up in the emergency room, secondary to overdoses. And then you want to understand that you want to collaborate versus coerce. I mean, I think that's a hard one for me because I want to tell people, you've got to take this, you need to be on this medication. It will save your life. But it may not be part of what someone is ready to do, and empower and give voice to these people. And we know that, like in syringe exchange programs and in peer-to-peer support, that people who have used drugs in the past that are in long-term recovery may have a better chance of meeting with people and working with people who are actively using drugs to help move them towards recovery. And really recognizes that there's inequalities and biases. So, for example, in poor or neighborhoods of predominantly Black and brown, you may find less people prescribing buprenorphine, and people may be consigned to going to a methadone maintenance clinic every day. It is the reality. It is the reality that, there has been a lot of inequality and biases. There's been a lot of incarcerations for mere drug possession, and that has disproportionately affected brown and Black populations. These kind of strategies could cause harm. Provide all or nothing. Okay, if you don't want this, I'm not going to do anything for you. You've got to take this. Or on the other side, I think I find it sometimes in palliative care, when we have someone with cancer, I'm just not going to pay attention that they're using, or I'm not going to really point out the dangers and harms of use. I mean, I work in the palliative care realm and work with people saying, well, do we really care? These people are going to die anyway. Not necessarily. And really being honest and ignoring inequalities and vulnerabilities. I mean, they exist and we need to be able to call them out. Or just, like I said, have a fatalistic approach. Well, this is the way it is. The person's going to end up overdosing. And I think I tend to be that way and just say, well, they're going to overdose. We don't really have much else that we can really do. We've tried our best, oh, well, instead of is there anything else we can do? Can we actually, if we're not going to be able to move someone towards recovery, can we just talk to them about safer use, like ingesting, inhaling, and snorting versus injecting, or using clean needles when they inject. So making sure they always have naloxone, not to use alone. So can we use those type of strategies with people? Now you're probably thinking, wait a minute, I haven't talked about anything about acute pain management, but I think these are the overriding principles that we need to be thinking about when we see our patients, whether it's in the acute care or the ambulatory or home care setting. So we want to always make sure that the patient leaves the hospital or with naloxone. And I say leave versus just prescribe because I've been shocked, dismayed to find out that my patients can get all the opioids I could prescribe and have a $1 copay and then have a $100 copay for naloxone. So we need to just make sure. And this is anyone who's diagnosed with substance use or opioid use disorder, anyone who's in active use, who's on medications for opioid use disorder, even those that are in recovery, not on opioid use, medications for opioid use disorder. The CDC recommends anyone who's on greater than 50 milligrams of morphine daily, and those that are at risk for overdose, frail, organ dysfunction, and have safety risks at home. So pretty much it's almost everyone. So again, we move back to this is a balancing act. How do we pick a safer opioid for overdose and diversion? Like, do we want to try to use buprenorphine? How do we pick a long-acting monotherapy and consider, directly served, like RN applying fentanyl patches, short fills, frequent visits, try to minimize co-prescribing benzodiazepines and opioids. And how do we reduce harm? Again, I pointed it out, using with another person, overdose education, goals to reduce, like, say, alcohol. I mean, when we think about substance use, I mean, alcohol is the most frequently used substance. Now, it's legal, so we say, oh, well, it's legal, but it is one of the most frequently used. And so, and we want to acknowledge the person's life history and give positive regard, which is, and we can do this by using motivational interviewing. Like, can I have my patient who, really wasn't able to give up alcohol use throughout her life and actually was drinking all the way through till her death, but we worked to treat her pain with buprenorphine before she went on to hospice. And then when it became too much to use the buprenorphine, we went to full agonist opioids, recognizing she wasn't going to stop drinking, but how do I minimize any harm? So we'll start with the case. I wish I could show you the video of this patient. And she was one of my patients who was admitted to the ICU with respiratory distress, and during that admission was diagnosed with small cell lung cancer with extensive osseous metastasis. She was in active intravenous drug use, regularly using heroin. This was before the flooding of the market with fentanyl. Most people who are using heroin now, at least in the Northeast, are probably getting mostly fentanyl. Occasionally used methamphetamine. She had a lumbar abscess and had chronic back pain status post a laminectomy. She lived in a boarding house. She had twin daughters with active injection drug use, and in fact, one was hospitalized at the same time. During the hospitalization, as was the practice, she was started on methadone, so to prevent withdrawal and to treat the substance use disorder and pain. But somehow during the hospitalization, the hospitalist thought she had an intolerance to methadone and rotated her to oxycodone extended and immediate release and discharged her with this and sent her to me for follow-up. And she calls 2 days after discharge for a refill. She's out of meds. And so how could we have better managed pain in this setting? And some of you might have thought, well, gosh, why would we have done this? I mean, why would we have even done this? Well, remember, she has cancer. And so people thought, well, she's got cancer. I'm not going to worry about the fact that she has opioid use disorder. But we do need to, because not if someone's not imminently dying, we need to think about that. So when we have someone who comes into the hospital with acute pain with active substance use, obviously getting a good medical history, including the substance use assessment, like what are they using, when was the last time they used, looking at withdrawal assessment, what is their social situation like, and we want to obviously use non-opioid multimodal analgesia. If the person is willing, we want to start medications for opioid use disorder, whether that's methadone or buprenorphine. We'll talk about you won't be able to use buprenorphine if they're not in active withdrawal. I say use an intravenous patient-controlled analgesia or scheduled opioids. Some people have concerns about using PCA in this population, worried about tampering with the lockbox. But we have to remember that people will probably need higher doses of opioids because of tolerance. This has been shown that, due to tolerance, people require higher than usual doses of opioids. And sometimes using scheduled versus PRN takes the burden off the patient who's clock watching, maybe because they feel like they need the next dose because they're in pain. And it also takes the potential stigma of the nurse labeling that patient as drug seeking or clock watching. So we also want to treat withdrawal symptoms. So the clinical opioid withdrawal scale is one scale that can be used. There's also the subjective opioid withdrawal scale, but basically you're going to score it, and whether they're in mild, moderate, or severe withdrawal. And we want to be able to, and looking at and things that you want to think about: sweating, restlessness, pupil size, bone aches and joints. You'll hear people talking about feeling like they're ready to tear their legs off. Looking at runny nose, tearing, a lot of goose flesh skin, anxiety, irritability. And so you want to think about those type of things, because then that will guide your treatment. Now these symptoms are not all inclusive, but you want to think about these symptoms and use the scale. One of the things that we're seeing, there's a protracted withdrawal from illicit fentanyl. So what does that mean? Is that, like, even though the fentanyl looks like acutely goes out of the system, you'll talk about people that will be then started on buprenorphine that get pushed into severe withdrawal. And part of it is because this fentanyl, which is much more potent than what we use in the for the clinical setting, also stores in adipose tissue. So obviously the withdrawal treatment, first of all, is methadone and buprenorphine, but nota bene here, with buprenorphine, you cannot start it until someone is in withdrawal. Otherwise, you risk putting that person in worse withdrawal. But there's a lot of low dose initiations, which also have been coined as microinductions, that people are doing while people are still on opioids, meaning putting someone on a patient-controlled analgesia. And if that patient's willing to start medications for opioid use disorder, starting at a very low dose buprenorphine, like in our hospital, we're starting at 300 micrograms buccal buprenorphine and moving up to there, like to 1 milligram of buprenorphine to 2 milligrams versus the usual starting, which is like 4 to 8 milligrams the first day. You want to use alpha-2 adrenergic agonists to help treat. This are your things like your clonidine. There is an FDA-approved medication for this as well. Basically, this is to help decrease that noradrenergic response, and so anxiety, irritability, and obviously symptomatic treatments of cramps, nausea, insomnia. And we actually, in the hospital setting I work, actually have a symptom management for the medications for opioid use disorder. If we were initiating buprenorphine, there's a checklist of what we can use. Although the literature's not been really strong to support some of it, I have patients that have gone through recurrence of disease and withdrawal so many times, they'll come in and tell me, listen, you got to give me the gabapentin. I know that that's what works for me. We have to remember to screen for withdrawal from cannabis. I mean, you're thinking, what? Withdrawal from cannabis? But really, there is cannabis withdrawal symptoms. And if you work in an acute care setting that doesn't allow the use of cannabis within your setting, and you have someone coming in that's been using daily cannabis, they may get withdrawal symptoms. Now, it's not going to be the same type of thing that you will see with opioids, but you'll still see anxiety, irritability, disturbed dreams, mood changes. There's really no strong evidence. Some people say using cannabis agonists, like sometimes I'll put people on higher doses of dronabinol in the hospital. I might use supportive treatments like maybe a little bit of low dose benzodiazepine to help with anxiety or to sleep. Obviously, supportive counseling and talking about it, and maybe even screening. Does this person potentially have a cannabis use disorder as well, or are they using cannabis to treat symptoms? Because that's the other thing, is that you may have someone who is using it to help treat symptoms like nausea and vomiting, and then all of a sudden you'll have the recurrence of symptoms. My goodness, what about stimulant withdrawal? Okay, stimulants have made a resurgence of use. We're seeing more methamphetamine, we're seeing more cocaine, and we're seeing a lot of times it's being mixed with fentanyl. So you may have someone coming in that has both, and so you want to look at the acute effects: hypertension, tachycardia, hyperthermia, psychomotor agitation, and on the extreme end, seizures, and you want to make sure that you're providing supportive treatment. But you also may have confusion, paranoia, and anxiety. There's no specific antidote. So we don't have like naloxone, we have for opioids, flumazenol, for benzodiazepines. We just want to treat the life-threatening conditions, provide a quiet environment. Long-term things like motivational interviewing, cognitive behavioral therapy, contingency management have been used. There's been question about stimulant replacement therapy, and I have someone who's regularly using methamphetamine, and I do have her on dextroamphetamine for ADHD and for fatigue related to her cancer. And I've often grappled if I'm doing the right thing, and there have been some case reports. Does this potentially help people to decrease their use of methamphetamine? So we all have probably been exposed to what is multimodal pain management, but remember that different medications work at different pathways along the pain continuum. So your local anesthetics, your anti-inflammatory drugs work at the source of trauma. Same with your anesthetics. When the signal gets pushed up into your dorsal horn, this is where you're going to see your opioids, your alpha-2 agonists, obviously into the brain. But you're also going to be able to see in terms of your tricyclics, your serotonin, norepinephrine reuptake inhibitors, your spinal thalamic tract, and your anticonvulsants. And then non-pharmacologic, biofeedback, guided imagery, virtual distraction, virtual reality. All of these things can be potentially utilized to treat the pain. But remember, if we've had someone who's been using a lot of illicit medications and opioids in the outpatient setting, we want to make sure that we are treating the pain, and we may need to use higher than usual doses of opioids. The most important thing is, what are we going to do when this patient gets discharged home? Is there a prescriber after discharge if opioids are necessary? And we want to avoid a gap of care if plans to continue medications for opioid use disorder. I've seen this happen. I've seen us sitting in mortality and morbidity conferences when we've had patients that had a gap in care. They were leaving the hospital. They were going to get connected with the outpatient clinician in a couple of days, were discharged without medications for opioid use disorder, and died. We want to make sure that we prescribe and have in the hand naloxone, because there is a higher risk for overdose due to loss of tolerance. I had a patient that was in for a couple of weeks with a hematologic malignancy, who absolutely refused to go on buprenorphine for his opioid use disorder, had torsades de pointes with methadone use, so that's not an option. Probably didn't want to go on it because even when he was on methadone, still was using a bag a day of fentanyl. And so obviously knowing that buprenorphine wasn't going to allow him to continue to do that. But I worry when he left that he had been in the hospital a couple of weeks. He was at high risk for overdose. So let's look to a second case. We have a 55-year-old man, a patient of mine with alcohol use disorder, opioid use disorder from prescription opioid use, with chronic abdominal pain. He had a pancreatectomy secondary to his alcohol use disorder, 3 myocardial infarctions, depression with suicide attempts, and severe peripheral artery disease. He was currently really well controlled on buprenorphine, 24 milligrams times 24 milligrams in divided doses. And so he has a planned surgery for peripheral artery disease, and he is afraid because he's like going, I'm stable, I'm doing well. I'm really afraid they're going to put me on opioids. And so how do we manage this perioperative pain? So a quick overview, for most of you may know, but medications for opioid use disorder. So remember, methadone is a full mu agonist. Usual doses are 60 to 120 milligrams daily. When it's used for opioid use disorder, it's once daily, and it must be administered through a federal opioid treatment program, which is really unfortunate that we have a lot of these restrictions, but this is the way it is. The patient goes daily for observed doses. If they're doing well, they may graduate to take-home doses on weekends or have weekly pickups. Now, if we're going to treat pain with methadone, the analgesia only lasts 6 to 12 hours. So we have to dose it more frequently. Methadone has a lot of drug-drug interactions. It can cause QTC prolongation, which could cause torsade de pointe. Buprenorphine, again, is a partial mu agonist, and it's usually dosed at 8 to 32 milligrams sublingually or transmucosally daily. It has no bioavailability, and it can also be used 100 to 300 milligrams subcutaneously monthly. It can be prescribed that anyone that's listening to this, if you have a ability to prescribe medications. You just need to get a waiver. You don't need to do any educations. It previously had been 8 hours for physicians and 24 hours for physician assistants and nurse practitioners. I actually think the education is wonderful. I learned a lot. It's usually they're using lectures from the American Society of Addiction Medicine, their board review course. I think it's great. It's got analgesia if it's given in split doses, and I think that this is where the challenge you'll come with patients who will say, it's not going to help my pain. I know it's not going to help pain. Now, it used to be thought that if we gave pure mu opioids, that you could override it. And we're finding that's not true. You can. It just may require higher doses. And so this whole notion that we had to stop buprenorphine if we were bringing someone in to the hospital and for an acute event like, say, a surgery has changed. Now, naltrexone is a full mu antagonist, so it's given either daily or as a monthly depot. And so it's administered by any clinician who's a prescriber. It's also used for alcohol use disorder, and that's what it was originally used for. It blocks the effects of opioids, so it's not a good choice for those requiring opioid therapy. And if you have someone that comes in for like an emergency surgery and they have a depot injection, you may have to give 20 times the dose of opioids to get an effect. So buprenorphine works differently than other opioids. So when you look at the percentage of mu receptor intrinsic activity, you can see it's much lower with buprenorphine than it is with your full agonist opioids such as heroin and methadone. So there's potentially a decreased risk of overdose because you reach a ceiling dose, the more you will take in terms of the potential risk for overdose. Having said that, if someone is utilizing a lot of benzodiazepines or other opioids over it, of course it still can happen. One of the other unique properties of buprenorphine is that it's a kappa antagonist, and there is potential that it may actually help with things like mood or depression, which is being studied. Someone said, well, I don't want to give buprenorphine just to help with someone's depression, but so someone has both. So how do we manage acute pain for individuals on medications for opioid use disorder? Obviously, we want to know what they're using. We want to verify their medications. If they're on naltrexone, we want to absolutely stop it. And although there's not specific guidelines, more and more people in the addiction world and the pain world are saying we should continue methadone because the discontinuation is not recommended by most experts. Some people will actually decrease the dose of the buprenorphine to like 12 milligrams daily, hoping that they'll free up enough mu opioid receptors to better treat with full mu opioids, but others argue that's not necessary. Again, we're going to need higher doses, even in those potentially that are using methadone, just because of tolerance over the ages, So, and obviously naltrexone, we need to use multimodal analgesia, regional analgesia, as needed opioids, but you must use much, much higher doses, And we want to make sure that when we continue our non-multimodal analgesia, you want to continue methadone or buprenorphine, and you may need to consider increased dosing if postoperative pain or use split dosing, but you need to collaborate with that outpatient treatment provider. And that's what's really important, because what are you going to do at discharge, And so, again, you're going to need with the person on naltrexone to really educate about risk for overdose, naloxone prescription, and then you can resume naltrexone once pain's resolved. But if pain is going to continue for a while, do we need to transition that person either to buprenorphine or to methadone? It's really important to consider prevention of overdose after hospitalization. As you see, I have said this multiple times, and it's because I worry about it, because I've seen it happen. So if the medications for opioid use disorder were discontinued during the acute care, we must activate a safety plan. We must restart it prior to discharge if possible. And if we're not able to restart naltrexone, we've got to counsel about the risk of overdose. And it should be in every patient's hands for discharge. Now, what do we do with the patient who is in recovery, who's not on medications for opioid use disorder? Well, again, multimodal non-pharmacologic approach and really education and counseling if opioids are necessary. And this really, people may feel that they've maintained the recovery for a long time, and the last thing that they want to do is to restart an opioid. And this is where we really need to talk with people, continue and engage in psychosocial program. Remember some of our peer supports, like our Alcoholics Anonymous, Narcotics Anonymous. Some of them still have a no drugs approach, even in terms of medications for opioid use disorder. And so it can provide challenges for some people. Some people will attend some of the meetings and just won't disclose their use. Obviously, again, if you take one thing away, your hand will make sure that you write for naloxone and that your patients can get naloxone. And so looking back to the balancing act, again, it's, risk mitigation. Again, what is the safest way I can prescribe? What can I do to minimize the harm of potential overdose? But also being aware of our own stigma, being aware of our own bias, and then, how do we utilize a harm reduction approach, and, we want to engage in conversation, safer use of alcohol, stimulants, and opioid, ingest or snort instead of inhale, safer injection practices, not using alone, making sure naloxone's there, overdose education, goal to reduce alcohol. Should we be adding medications like acamprosate or off-label use of things like topiramate or gabapentin? Not using, things like cocaine and alcohol together, which could increase toxication, and, acknowledge that this person's life history, I had patients, one of my patients that I absolutely adored, she started drinking alcohol at age 5. What happens to a brain when you start utilizing a medication at age 5? What happens with someone who develops an opioid use disorder because they were exposed to opioids? I have another patient who had Hodgkin's lymphoma at age 10, so was exposed to a lot of opioids early on. And then when it ended up with an immuno disease that caused significant arthropathy, was placed on high-dose opioids. And even though had not been using illicit opioids, moved right into using opioids not as prescribed. Now, was part of this just epigenetic, like does he have some genetic predisposition, to opioid use, misuse, and also the early influence, and really thinking about how do we motivate and engage someone, even if they're not ready to change, knowing that if they felt heard and believed, that maybe the next time they came in the hospital, they may be ready to engage. So always consider a multimodal approach to pain management and include the treatment of comorbid mental health and substance use issues. Ensure that the individual has naloxone in hand when discharged and collaborate with clinicians. Treating substance use or opioid use is essential to ensuring appropriate pain management. Thank you so much for listening.